seminar, which forms part of our Reimagining Child Health series. This seminar today is being recorded, just so you know. If you have any questions during both presentations, please write them into the chat function, and we will take questions at the end of both talks. For those who like to use Twitter, please think of using the hashtag Reimagining Child Health, because that would be good, since this forms part of a series. We have two very good speakers here today, Professor Rhee and Dr. Mary Hughes. And I'm going to introduce Mary first. Dr. Mary Hughes is an associate professor here in our school in Trinity. She has a special interest in the health and well-being of children and young people with chronic illness and asthma in particular, and also mHealth and digital intervention developments to support engagement in self-care and improvement in health behaviours. Mary has designed the National Asthma e-learning programme for the Asthma Society of Ireland, and she's currently involved with me and my team in the PACE study, which is an intervention to promote adolescents with type 1 diabetes engagement and healthcare encounters, and also the EU Gravitate Health IMI project on improving access and digital health information for the safe use of medication and improving quality of life. From her involvement in the National Advanced Practice Networks, Mary will highlight some of the interventions introduced across the children's services and highlight the impact on the lives of children and their families. And I'm really looking forward to hearing your talk, Mary. So the floor is open to you now.
Thanks a million, Imelda, for that lovely introduction. It's great to be here. I'm just going to share my screen with you, and we can kick off proceedings. So it might just take a second here. Okay, so you're all very welcome here today. I'm delighted to be the first to open the series here from the school on reimagining child health. And I would encourage you, all those who are tweeting, to use our hashtag today, and hopefully we'll get Twitter trending our wonderful theme. I'm just going to basically give you a snapshot of my history involved in mHealth intervention development and how I arrived at that, and how I'm working with clinicians across the service to try and impact on the lives of children and their families and improve their self-care behaviours. I'm also going to just give you a little snapshot of what's happening out in CHI as well, because there's wonderful work ongoing. So it's great to have the opportunity to be able to highlight the excellence that our colleagues are engaged in out there in practice. So the reason why I became involved in mHealth and interested in mHealth development really stemmed from my PhD studies, where I was doing some research with young people who have asthma. Now, we know an awful lot about the trajectory of asthma and how it affects so many children in this country. Roughly about 1 in 10 currently in the country have asthma, and 1 in 5 children at some stage in their lives will have asthma. And teenagers and young people in particular run into particular issues. So when I worked with them and they spoke to me, it was really, eye-opening to learn from their perspective, because I'd always viewed asthma through the eyes of myself as the nurse looking after them and the service that we were providing. So they would explain to me that they saw their clinic consultations with us and their interactions with healthcare professionals as playing the game. They knew what questions to ask, how to get in and out of consultations well, and they didn't necessarily always engage well in consultations with us. So that then triggered with me, well, it was time to consider how we could do things a little bit differently. You know, what and who were we competing with in order to get them and keep them engaged in their own self-care? And how do we tap into that screenager generation? How we've done things traditionally may not necessarily work with the current generation of children and young people who are coming through our services. The other thing that I was really interested in is finding out and developing a greater understanding of what parents use to navigate and keep track of their child's health progress, because they didn't have a system where they could manage this, digitally at home at that time. And that led me to believe, could an mHealth or an eHealth intervention augment what the current service delivers and enhance their engagement in their treatment in that out of hospital setting? So it triggered me to think, what were we expecting of them? Were we really expecting something that matched their capability? Even though they had this chronic condition for a long period of time, their understanding of their condition, of their medication, of triggers, of all those things that we take so much for granted, wasn't what I expected for somebody to have at that stage, having had asthma for a number of years. And then that led me to believe, right, what could we do? How could we engage with them to design something that they would find useful? Because that was key, something that actually grabbed their attention and kept and sustained their engagement in their own healthcare. So it was there then that I linked in with the Asthma Society and with other agencies, and my journey into mHealth and digital health intervention began. So mHealth really will enable us to do a huge amount of things across healthcare. So if you can use it in areas of health promotion, in surveillance, to set up simple reminders, or to design interventions that can help improve behaviours. And this really is where I'm currently quite engaged and involved. So we know that there are over 40,000 children already from an asthma perspective registered with the Asthma Cycle of Care programme. So what is it that we can do to bridge the divide and get everybody to have joined up thinking and have systems speak to each other so they're not doing things in isolation? Why this is particularly important for children and young people with asthma is because we know that they're missing out on an awful lot of the things that we would associate with childhood naturally. They're missing 5 days of school per year. We've got the second highest discharge rate from hospitals in Europe for people with asthma. So what is it that we're doing that's just not allowing them to maximize their control of their condition? Is there something that we could develop? And this is really where my work is centered on. So we know with mHealth development, if you can have an educational component in addition to a behavioural change component as part of your app development or your mHealth, then this is much more sustainable. You get greater and more sustained engagement from the user, and therefore you have a much better chance of success with your intervention. So you have to appeal to your target group, make sure that it answers their queries, that it's personalizable to their particular condition, because transferring what we have on paper and just simply putting that into an app won't work. It needs to be a lot more interactive for them. I learned an awful lot about what to do and how to do it well from the National Asthma e-learning programme that I developed on behalf of the Asthma Society of Ireland. Program that has been rolled out in secondary schools across the country, and in the first year that it was rolled out, over 10,000 children took this program, typically transition years, but it was linked to their SPE program within the schools. And what they told me in the evaluation phase was that you have 30 seconds to get my attention. You have to make it interesting if you want me to use it. So if you don't involve them and engage with them and make sure that it's something that's appealing to them, that sparks their imagination, or what can I do with this, or how is this going to help me in my life to do the things I want to do, then they're going to switch off and they'll disengage. So they may sustain it for a couple of weeks, but we know the average length of engagement ranges to about a month to 6 weeks with most health apps. So combining that educational intervention with a behavioural component is really, really important. And then making it more interactive, making it like the other devices that they use, that there's this interaction with the actual system and programs that you're using chatbots, all of those kind of things will sustain the user engagement as well. And the key to this is, what is everybody else doing? You don't want to reinvent the wheel. Is there something there that's working that you could improve upon? Or is there something that you can work, we're not the tech experts, and I'll hold my hand up and say, if you ask me to program an app, I'm the wrong person to do that. But what I can do is I can tell you what needs to go in there from the health perspective, what works, and engage with the young people and work with them on developing it. And then as part of the team, the tech end will be supplied by somebody who's the expert in that. So, you play to your strengths when you're developing these kind of interventions. The most important thing is that the young people themselves, or your target audience, are engaged and involved from the outset. So doing these interventions has changed my whole perspective on what we do. So when you speak to young people and you're asking them what they want from mHealth, they're very upfront, and they will be quite honest with you in telling they want to have a very positive experience. It has to be meaningful for them. They want good information. They want it from a verified source. You know, if you go onto the App Store, there's over 600 asthma apps available currently. Some are free, some you have to pay for. So how do you help them select one that's suitable for them? Are they all suitable? Some of them haven't been updated in the last 2 years. The tech that they're based on is now outdated. It won't work with a lot of the modern smartphones. They're quite flat. You know, they're marketed at health and fitness, at education, at medicine. There's a whole range of different criteria. So if you're a health professional, how do you know the quality of the app that's there? Never mind to recommend to young people, never mind if you're the young person who's looking for an app and you want something that's going to work for you. If you've tried a few that really don't, you know, float your boat, you're not going to engage with them anymore. So you need to make something that will work and that is simple and easy to use. No gimmicks, where there's no risk of any sociable kind of undesirable effects of using this app, where their data will be private and there's no risk to their own confidentiality of their symptoms. The other big thing is they want a tracker. They like those targets that you can set them a goal and they can see what their performance is like, how they're achieving their own desired outcome. So that sort of data capture is really good in terms of sustaining their use in your development of your app. So, you know, design it with the market in mind that you want to tap into, co-produce it with the young people, get them involved early, and this has certainly worked for me in my work, and make sure that it's available across platforms. Now, there is a cost to this, but it's absolutely essential, because when you do go down through a lot of the apps that are available, they're either only available on iOS or on Android. All of them are available across platform. So it is something to consider before you start developing your mHealth intervention. How are you going to actually access, how are the users going to access this on a range of devices? It has to be compatible with them. Obviously, the cost of availing of the intervention is important as well. So if you can make it free, then you're going to get a much greater uptake of it. And the validation and recommendation of health experts of a government body or of other agencies really is very important in terms of the trustworthiness and how much the faith the end user will actually have in using this app, in taking on board the health information that's within it. And in trying to set their own goals and targets. So this is really key, co-development. It's not for the faint-hearted. There are quite a lot of considerations that you need to take into account when you're developing mHealth, but it's absolutely worth it in planning your intervention well and setting yourself up for success. So, you know, the more gamification you can have built into your app, the greater the sustainability of it, and the more interaction and the longer, the more sustained use the end user will have of it, especially if they see that it's working for them. They nearly want this instant, you know, return for their efforts in engaging with it. So make sure that you're setting the targets at different levels so they can actually personalize it to their own ability and capability. You need to be able to keep up with advances in technology. It's changing all the time, so it needs to be current. It needs to be compatible with different platforms and with different devices. And obviously going through all the data protection safeguards is essential. That is really key to your success. If you are having a moderator function built in, you just need to be careful that, you know, you have to be able to sustain that. Quite a lot of people who will develop an app will have a moderator function in there, but that's a huge cost over time if you're going to sustain this past a testing phase of an app. And you also need to make sure that the moderator is available 24/7 to people. So again, that is something to consider. So consider your development and support costs, and this really is what can be the make or break of a lot of the interventions that are developed. So the purchase point for the end user is important as well. So they're a discerning audience. So make sure that your product is fit for purpose and that it is something that they're actually going to use and engage in. It's really timely that we're talking about mHealth and eHealth, because we can link into our national strategy. And if this is something you're interested in, certainly this is the key to getting funding to actually develop it, to forming those partnerships and relationships with other people across the country and across the EU, and our colleagues in the States, in terms of the development of software that can be used and link into our existing systems. So using and linking into that eHealth policy is essential, and this can be linked then to Sláinte Care as well. So within the Sláinte Care report and framework, there is designated funding being made available for digital development, and we can see that. It's placing the patient back at the centre. So again, it's all about empowerment, and this certainly for young people with chronic conditions is really, really important. So if we can keep children and young people well and keep them, and have their care closer to home, where they don't have that unscheduled interaction with us in the health services, it's going to have dividends not only for them personally, but also for us within the health service, and it will help reduce waiting lists, unscheduled attendances at EDs, out of hours GP services, and all the rest. So if we can equip people with the tools to stay well and stay healthy and stay at home, then this is all part of the jigsaw. It's not sufficient on its own, but it's an adjunct to all the things that we're all doing within the health service. And this again feeds into the EU task force report and the redesigning of health in Europe. So it's all about linking in and isolating where you can actually get support and develop your idea further and realise what can be achieved with mHealth and eHealth. We all know about the advances and the development of the new children's hospital. So again, think about what we're developing next, make sure that this will link into hospital systems. So we know that there's been huge investment and the design phase for the new hospital is well underway. So we're looking at all the databases, all the systems that we use across hospitals, and joining them together so that there will be a single place where we can store information and manage our new hospital when it opens. Now we can see that the Symphony system in the ED departments has rolled out, and it has been hugely transformative in terms of children's cares within those ED departments, and also the Evolve system as well has been rolled out, and it's working very well. So this is slowly starting to integrate into our health systems. So if we can add into that and make our interventions more integrated into them, they're going to be much more useful and sustainable in the long term. I think, we're all living through this COVID pandemic, and we can see lots of negatives, but there's been huge positives in terms of health service and the transformation of health service and service delivery during this past year. And maybe it has been that push that we needed to take that risk and to actually go out and develop new interventions. The pressure points in service have been identified, and we've been almost pushed into the online space in terms of our business and how we actually consult with our children when they're not in the hospital, and even within the hospital we're using it more and more with each other. So I think there's almost every service now has online consultations. The surveillance and sharing of clinical data, you can see the transformation there, and new operating systems linking up tertiary and community services. It goes without saying that our advanced nurse practitioners and clinical nurses have really been driving a lot of these developments, and they've been leading out and involved in teams across the CHI and across the national network of children's services in revolutionising how we're doing our business. So there's been this hybrid approach. Now there's a lot of evaluation going on. So I just wanted to give you a couple of examples of what's going on. So the first one that I wanted to highlight here was the work that Michelle Doyle is doing in CHI Temple Street in relation to the hospital clinical portal that she has developed in the urology service. And she's evaluating this as we speak. It's been rolled out, and it really is streamlining the service for the cohort of patients within the neuro service in Temple Street. In diabetes as well, in CHI Tala, they've translated what they were doing in person in terms of their school education systems into an online system. And Helen and Martina have been doing brilliant work out there, and they're currently in the phase of developing, of evaluating what they've done. So small period last year, they saw the same amount of people online to do this program as had been seen in the year previous for the entire 12 months. So it's much more labor intensive to go out to schools, whereas when we get them all online, you can cover an awful lot more schools in the same time frame. Mary MacDonald as well and the team out in CHI Tala, they've been commencing this remote monitoring of lung function in asthma patients with the aim to reduce the patient morbidity and use of unscheduled healthcare hours. So this is aimed at the over sixes, and it's about spirometry and for children who would have been admitted to the HDU or PICU or who have had 2 episodes of steroid treatment. So there's quite close parameters for the children who are going to be involved in this intervention. But again, Mary and the team are starting the evaluation of this system. So again, keeping these children well, monitoring them from a distance, having that 6-monthly checkup with Mary and the team. This is going to be very, very beneficial to them in the long run. Catherine Carrick as well in CHI Tala, she's developed this new online poster that is available for everybody to help them with their asthma education and support. I know certainly I used the previous version of this lots in my clinics when I ran them, and the kids loved pointing them out. So something relatively simple, or we would consider simple, has a huge benefit to the children and their families and to clinicians across the country, having this visual aid. So we cannot thank them enough for all of these. And as I said, this is just a snapshot. There's plenty of other things going on across Crumlin, Temple Street and Tala. So I'm going to wrap it up there. I know my time, I could talk for hours about mHealth development and digital intervention development, but just think about mHealth. It's really the way forward. It's not the full answer, but it can augment your service. It can definitely improve engagement. We've seen that, and I've certainly seen that through my own work. You can get to those hard to reach cohorts or groups of people, and you can integrate it into your current information management systems and involve them from the start. Remember, the app is not there to replace nursing. It's there to support you and to support them in the community. So young people will really engage well with it there. So thank you. If you have any questions, I'd be delighted to take them at the end, or you can put them into the chat. And I look very much forward to Professor Ree's presentation. So I'll hand back to you, Imelda.
Okay, thank you very much, Mary. That was very interesting. Now I'd like to introduce Professor Ree. Professor Ree is from the School of Nursing faculty at the University of Rochester. And over the past 18 years, Dr. Ree has established a robust program of research on adolescent asthma. And she's received over $5 million of external funding from the National Institute of Health. So that's quite impressive, because I know they're tough to get money from. Her focus has been to improve asthma self-management in young people through the development and evaluation of innovative interventions that capitalize on cutting-edge technologies and the unique developmental opportunities that present in adolescence. Dr. Ree will present today on her work and introduce 2 of her projects and their impacts on the lives of young people. Welcome, and I'm really looking forward to your talk, Dr. Ree.
Well, thank you so much for the lovely introduction. My name is Mary, and I just tried to get my slide up. Don't know whether, do you see my screen?
Yeah, if you go down to the bottom there, yeah,
yes.
That's it. Well done, yeah.
Do you see it?
Yes.
Okay, I will, do you see the, there's the technology, right? Okay, well, I'm just want to say good morning, but it's not good morning. It's a good afternoon, you guys, because here is very early in the morning. It's not even 9 o'clock. But I'm very thrilled and honored to be here to present my work to the audience in Ireland. And I tried to put some on the slide that Irish, so hopefully you appreciate it. And then I just wanted to thank Dr. Hughes and the Trinity College School of Nursing and Midwifery for this pleasure. Okay, so this is my topic, and let me see. I just put up this this map just in case you're wondering where I'm from. If you see here, I'm pretty sure that you know Niagara Falls. So this is kind of major landmark that is close to Rochester. So I just put it up there. And then this about an hour and a half away from where I live. So that's where I live with my little puppy. Okay, so this is the university campus. This is half of the campus. That's we call it river campus because there's a river flowing next to the campus. And the medical center is right on the east side of this, this campus. And this, I will show you some pictures from the medical center. This is a children's hospital that was recently built. And this is the main entrance to the university main hospital. And that's the school nursing. And then my office is right there. But I haven't gone to the place for almost a year now. Okay, that's enough introduction. And this is my presentation outline. And I will just go over the asthma problems and the burden and pediatric patients. Pediatric asthma patients, I was going to talk about Ireland, but Dr. Hughes already shared some of the problems in Ireland. So I will just skip over very quickly. And then I will introduce two of my projects that are pertaining to mHealth interventions. As I said, this is a kind of quick overview, and I was digging through the internet and the literature to see whether there are any information about Ireland asthma problems. And it looks like you guys are pretty high in terms of the asthma problems, especially in pediatric patients. It's about the fourth highest current asthma prevalence in Ireland, and then fifth highest rate of asthma attack in the world. So that's quite impressive, but not in a positive way. So this is kind of another slide about the Ireland asthma issues, but I'm not going to talk about it because Mary already discussed that. And I just want to show you how asthma is prevalent in the US. Overall, the prevalence of current asthma in US has seen some fluctuations, slightly fluctuation in the past almost 20 years. But then, you know, if you see the prevalence from 2001 is a 7.4, and in 2018 it's a 7.7, although it's very subtle, but it's a statistical significant increase. So we have about 25 million people living with asthma in 2018, and of those, 6 million are children. This slide shows the asthma prevalence by age groups. And as you see here, asthma prevalence in adolescents at 11% is much higher than other age groups. And the asthma prevalence was also higher. If you this slide is about the prevalence by age and sex. So as you see here, in the younger age, you see much more prevalent asthma in male children, but in the adult, the actual trend become reversed, so that the females have a much higher instance of asthma. But in the adolescent time, it's pretty equal. So that's what we see here in terms of asthma prevalence. And this is a brief overview of the burdens of asthma in the US. And the asthma represents an increasingly serious health problem in children in the US. And like Ireland, asthma affects almost 1 in 10 children under the age of 18. And then these children are the frequent users of healthcare services and office visit and all kinds of ED visit and hospitalization, causing a huge financial burden to the families and the society. And there are effective treatment options, but then the asthma morbidity is continuously on the rise. Adolescents seems to suffer even greater asthma-related morbidities than younger children. And adolescents uncontrolled asthma often suffer from poor the quality of life, mostly related to the poor sleep quality and limited activities. And poor self-management is often blamed for this high asthma morbidity in adolescents. As you know, asthma has no cure, but it can be controlled if you exercise good self-management routines, such as avoiding triggers and taking all kinds of treatment, adhering to the treatment the plans. But despite these general ideas about self-management, there is no consensus as to what self-management entails in adolescence. So my students and I in the past do some concept analysis, and we publish it. And in the paper, we defined self-management as the set of behaviors that adolescents use to prevent, monitor, manage, and communicate their symptoms with others. So this diagram basically depicts those 4 areas of asthma self-management, and through the development of my mHealth application, try to address some or all of those domains of asthma management. And I'm going to skip over this slide because Mary already covered this sufficiently, so I will do that. And this is the first project that I'd like to introduce. The project name is the ADAM project. ADAM stands for the Automated Device for Asthma Monitoring. And this study was funded by the NIH about 10 years ago. Okay, so this device basically tried to address this, particularly the symptom monitoring components of asthma self-management. The symptom monitoring has been recognized as the cornerstone of asthma I didn't fix it. It should be self-management, because based on the symptom monitoring, patients often change or adjust their behaviors to address some of the symptoms that they are experiencing. And then also providers, that information is also very critical for the providers as well, because it can be the basis for the deciding the treatment options for their patients. However, literature, the literature has shown that adequate self-symptom monitoring has been linked to the positive asthma outcomes, such as fewer cases of asthma exacerbation and acute care visit, or high quality of life in children. Because of that, National asthma guidelines recognize appropriate symptom monitoring as the initial first step to successful asthma self-management. Conventionally, there are 2 types of symptom management methods that's been recommended to the patients. The first one is a peak flow meter monitoring and symptom-based monitoring. But then, these methods has its own issues and challenges. And for peak flow meter monitoring, the patient's poor adherence and inadequate technique often lead to inaccurate readings is a major problem, as you can imagine. And also for the symptom-based monitoring, poor symptom perception is a major issue, especially for those people who have had asthma for a long period of time, and they often get used to their symptoms and they ignore it, and they just downplay their symptoms. And also, this is not a good method to monitor nighttime symptoms because they're sleeping. But the nighttime symptom is a major problem, and mostly it's an indicator of uncontrolled asthma. And then also the children with the higher levels of symptom severity often fail to recognize their worsening symptoms that leads to serious consequences, such as life-threatening asthma attacks or even death. These issues in existing methods highlight the crucial need for an innovative approach to symptom monitoring. So we set out to develop an automated device that can objectively monitor symptoms and quantify those data. About 10 years ago, as I said, and then the study was conducted in 2 phases. First phase is development, and the second phase is validity. And if you want to know more about the development phase, there's a detailed information that has been already published, and I just want to point out some of the high points. The first step toward the development is to collecting raw sound samples. So what we did is we have about 29 active the teenagers with active symptoms, and have them record their sounds day and night for 3 days, so with using this digital recorder. And then once we collected those sound samples, so we we listened to those tapes and annotated and extracted those sounds, the different types of sound, and classified those sounds, whether these are asthma symptoms or there's environmental noise such as dog barking or baby crying and door slamming and so on. And then we had, okay, let's listen to what I have here first.
Aren't you? I love bears, aren't you? I love
there. So you heard this is sound sample clips. This is how we did it. Once we collect this raw sound, we just dissect those sounds and then classify the sounds like the speech sound, whether this is a normal breathing, or it's coughing and wheezing or something, and so on. And then we each sound we analyze by looking at their waveforms. So our job was to select all coughing and wheezing sounds, that is the asthma, the symptom sounds for people with asthma, and then we analyze them. This slide actually shows that the waveforms from sound clips for unique patterns in terms of time dimensions and also the frequency. So as you see here, you see the very distinct patterns of this sound. We have tons of other things, but I just have only 3 put up here. And you can see that the manifestation is quite different. So our job was to define these different manifestations into some mathematical algorithm to define each sound, whether it's just a coughing sound, wheezing sound, and speech sound. And this is a slide that shows the schematic overview of how this the sound data travel through the device. So once we collected those the raw sounds, the sound samples, and then go through this algorithm that has the ways to extract this, the segments of the symptom sound, whether it's a symptom sounds or environment noise, and then make sure that whether that fits the algorithm that we already predetermined. And if it's the algorithm, then the device will automatically recognize as a symptoms, as a legitimate symptoms, and then count it, how many. So that then the symptom data will be saved on the device. So this is the picture showing our prototype, the very initial stage. So this is we use the iPad as a platform to house those algorithms, and use the external microphone that is attached to close to the neck or chest, so that they can pick up the respiratory sound easily. And then we have the kids to carry it around all the time for 7 days. So that was our trial, and I just want to show you some little bit more improved Adam than previous version. We call it Adam 2.0. And this is the in this device, we're not only monitoring symptoms, but also we capture the activity levels here, and then also this is the symptom patterns, and then we also collected medication use, so that when patients see it, they can see their symptom patterns in the context of their activities and medication use. And then we also have the screen for the teens to record and track their medications, so that this data actually feed into this first screen. Okay, now let's move on to the validity phase, and just wanted to briefly go over what we found that is promising, that this is indeed a promising symptom monitoring device. I just wanted to mention before we move on is that wheezing algorithm, we weren't able to generate a sensitive and generalizable algorithm for wheezing, because it's a very subtle sound, as you know, and it has a lot of variations from person to person. So it's kind of very hard to get the algorithm that works for every different types of wheezing. So we, at the time, we were kind of in a short, time is kind of short, we have to move on. So we have to just decide to focus on only the cough algorithm. But because the coughing is the most common symptoms of uncontrolled asthma in pediatric patients, it can still be considered so the capacity to monitor coughing alone still makes the device as an invaluable asthma monitoring tool. So here, as we expected or hoped, the higher symptom coughing counts were associated with the lower lung function here, and also lower activity level, lower asthma control, lower quality of life, and the high use of healthcare utilization. So that supports the concurrent validity. Coughing count also the significant predictors of asthma control and quality of life, as well as quality healthcare utilization 3 months later, supporting the predictive validity of the device. Each regression model explains large proportion of variance of each outcomes, as much as 76%, especially for the healthcare utilization. And then we conducted the RC curve analysis to see if the device data sufficiently differentiate asthma teens from those without asthma. So our area under the curve was statistically significant, suggesting the device can indeed differentiate these two types of group. Using the cutoff of 20 coughs per day, the device was able to correctly identify 73% of those without asthma. However, its ability to distinguish asthma with the teens from those without is somewhat low. As you can see, it's about a little over 50%. It's because we ended up enrolling a lot of asthma teens without active symptoms. So they kind of behave like a non-asthmatic kids. So but then, you know, our device is still, this is not a diagnostic tool. This is more like a monitoring tool. So the risk of a low sensitivity is less of a concern, as long as it can identify symptoms when they occur. And then we're also looking into the user acceptability of the device. And as you see here, I kind of highlighted 3, about over 80% of the asthma teens, they said they like the idea that device monitoring asthma, and also they said that they will remember to use this device continuously. And about 70% of teens mentioned that they don't mind using the device for a longer period of time, like a month and weeks. So that is a positive, promising. And we also, at the in the individual exit interviews, the participants said that the device was cool, easy to use, and convenient. They also found it very helpful and useful in understanding their symptom patterns. And most teens responded that they would wear this device if it becomes available. This patent, the technology was licensed to a local startup company for further development for marketing. And they transformed the device platform from iPod to an independent wearable device, like as you see here. And they added an M to another M to Adam, because they wanted to highlight that, that this device can not only monitor, but also assist some of the management tasks. These are the 3 components of the device system. Here is a wearable device, and that is connected to the mobile app. And then these, both of these systems communicate with the cloud server where the data are stored. And the cloud server, they can communicate also the data with the providers and the researchers, so that they can see what's going on with the team's actual data. And the next slide shows the little girl wearing this actual device. And this is a soft and flexible wearable device that can be placed on the skin anywhere, on the chest or back or on the side. The wearable component houses several sensors, not only to monitor coughing, but also activities and all kinds, several vital signs such as temperature, respiratory rate, and heart rate. And the processing, analyzing this sound data real time can eat up a lot of battery power pretty quickly. So daily charging is critical, which can be done by placing the device on this cradle that you see here on the bottom for about 2 to 3 hours. And device can be charged overnight while continuously monitoring nighttime symptoms if they place the proximity to the user. And the fully recharged device can run up to 18 hours, and the device can store the data for 21 days. And the data captured and stored in the wearable components are transmitted wirelessly to a mobile app that displays symptom parameters as shown here, like the different kind of style. And the data syncing occurs automatically every 15 minutes while the device is in operation and when it's nearby. And then app also send out, they send out medication reminders and track medication use. And the app also has the place where you can record your peak flow readings or trigger exposures. And then the app can display multiple data on a screen so that users can see how symptom patterns change according to the changes in other factors, such as there's a coughing numbers and whether it changed after the medication, whether coughing kind of got lower or high, or symptom exposure, whether this coughing become higher, something like that, so that they will have a more contextual understanding about their symptom patterns. The data collected by both the wearable device and the app will be transmitted to the cloud, as I mentioned, and they communicate the data with a dashboard that they can display the current or historic data for each patient. So each patient can be, the study ID, or this is a device ID, or you can put the people's name and they just click on it and it shows all kinds of data that you can investigate further. It shows all the details about the symptoms and even the medication use, things like that. Okay, the next one that I wanted to introduce is called mAsthma. That is acronym for Mobile Phone-Based Asthma Self-Management Aid for Adolescents. While ADAM was originally developed to address only symptom monitoring domain, the mAsthma was designed to address all 4 domains of asthma self-management. Well, probably I don't need this graph because we know that pretty much everybody has a cell phone these days. Even in Ireland, it's over 100%. This one show, okay, the texting function is very popular and used by almost all cell phone users on a daily basis. I'm sure that you have your mobile phone with you, and then you probably texting to somebody even now. Okay, so the mobile phone is owned by over 95% of American youth in 2018, but I'm sure it's close to 100, like, this year or last year. And then texting is a predominant daily mode of communication for adolescents, especially in older teens and girls. Interestingly, teens with the lower income families tend to use texting more frequently than those who were of high socioeconomic status. This graph shows the changes in teens' favorite way to communicate with their friends. And about half of the teens preferred in-person communication in 2012, but the rate dropped to 32% in 2018. On the other hand, the texting communication was increased from 33% to 35%, which makes it the most favored way to communicate with their friends in 2018 for teens. So there's a potential there. So capitalizing on this widespread of cell phone ownership and the popularity of texting, the application of text messaging in healthcare has been a huge increase in the past decades. Text messaging has several unique advantages over smartphones. I mean, smartphone is it's good, but you have to have a data and you have to have a Wi-Fi access. But this the texting, this simple texting, doesn't require any of those data or Wi-Fi access. It can be used anywhere and anytime, pretty much by anybody who has any types of a mobile phone. And the content and frequency of texting can also be tailored. It can be tailored to accommodate their changing treatment plans that will enhance clinical relevance and usefulness of the information being exchanged. So these unique advantages make the text messaging an ideal tool that integrate and coordinate complex routines of disease management into everyday life. So text intervention for asthma management has been predominantly tested for adult patients, and then it's very limited uses for the teenagers. There are about only four empirical studies in the literature reporting the application of text messaging for teens with asthma. And these studies use the texting programs primarily for medication reminders with no to minimal capacity to interact with the users. Therefore, there's a need for an integrated texting system that can be used as a comprehensive tool to support a broad spectrum of self-management activities beyond just medication adherence. I just wanted to give you a brief overview of the design of this system. The core of the intervention is this type of system is a natural language processing technology that is applied to texting communication. So unlike other texting systems that limit the user's response to the numeric forms, like a scale 1 to 10 or a keyword, yes and no types of thing, the natural language processing technology allows users to interact with the system conversationally, as if they are communicating with their friends or with the human. So it's like a Siri in a texting version. So users' experience with the system likened to a real-life conversation is to increase its appeal to the teens and enhance their long-term engagement with the intervention. In this sense, the mAsthma system represents a major paradigm shift from existing texting intervention as a conversational AI agent. Another innovation on this system is that its capacity to incorporate a parent in its operation by sharing information that the system collected from the teens with the parents by sending out some reports on a daily basis, so that it can facilitate communication or partnership between the parent and teens around this asthma management. So here are the 6 tasks that asthma can carry out to assist the asthma self-management. The first one is a symptom monitoring. So there are standard symptom monitoring questions being sent to the teens in the morning and at bedtime. And then there's a medication reminder and at a scheduled time. And the peak flow monitoring, if they have symptoms, it will prompt the kids to use a peak flow meter, and then they record that data on there, and then the system will let them know that what color zone they are in, and then with a simple feedback. And then trigger watch. So again, if they have symptoms, then it will ask whether they've been exposed to any potential triggers that cause their symptoms. And also the clinical appointment reminders. Teens forgetful, we all know that. So this is actually teens found it very useful. And also the summary report that's sent to the parents and the teens as well. That has the summarizing the symptoms, medication use, and all this information that we collected. So this is the schematic overview of the system operation. And the main function of the system is the interaction between the teens and the system. And then based on the information that this system gathered from the teens, it actually summarizes and generalizes the information, generate the summary report, and then transmit to the parents. And then parents can access to the data via email or texting. But a lot of our mothers, they prefer email, so we send it to their email address. And then when the system receives the messages that are too complex, have like a multiple kind of messages, or it's so vague to be processed automatically, then it will prompt the wizard, which is a human, so that that person can intervene and take over the conversation temporarily. The wizard is also oversees the interaction between the teen and the system periodically to check to see if the information being exchanged is adequate, so that we can ensure the safety of the interaction. We pilot tested this system as well, they published, and so there are details, and I just wanted to go over very briefly what that entails. As I mentioned, there are some the monitoring question that is sent to everybody in the morning and at bedtime, and these are the standard questions. 6 questions that were sent out. The average response rate over the 2 weeks period were pretty high, from ranging from 81 to 97%. And then also we encourage the teen to initiate conversation with the system by sending messages related to asthma. And then we have about over 400 teen-initiated text messages that has also been processed by the system. And these are the snapshot of the texting interaction between the system and the teen. Here you can see how natural the conversations flow, and many teens don't even realize that they're talking with the machine because of the response they receive from the system. In the parent report, as I mentioned, there's symptom control, activity, and all those things that we obtained from the teens. And then with the focus group study, with the parents and teens separately, and both agreed that it's convenient, it's easy to use, and then they like the asthma system because it helped them to be sensitive to their symptoms and triggers, and also they help them to adhere to the medications. Also, by the kids like the idea that there are something that they can talk to when they have the active symptoms, so that they can get some advice. So they kind of foster the sense of control over their asthma. And the parents, they love the parent reports. And then they stated that the parents' report was very helpful for them to initiate the conversation with their teens around the asthma, also become very proactive in helping their teens to manage their asthma. And then this is the kind of, after the pilot study, we added a clinician dashboard. As you see here, this is where all the patient information get tallied, or this is displayed for the clinicians. And if there's a high risk teens, then it will identify those teens. The high risk means the high symptom levels or the poor adherence. And if you click on the kid's name, and it shows all the detailed information about the patients, and then all this nice summary of the symptoms and medication use of the particular child. So in conclusion, these systems are multifaceted and interactive system that helps adolescents coordinate and seamlessly incorporate multiple activities of self-management, as we have reviewed. And also both system has, and then this both system is technically feasible and well received by the potential users. The next step is a clinical trial. So we will have to make sure that this system is indeed making some differences in terms of asthma outcomes. So that is going to be my next step. And then also we will have to find the ways to disseminate and implement the systems as a consumer products, and also integrate into the healthcare system, as Mary mentioned. So that's our next step.
That's very good. Thank you very much, Professor Ree, and Mary, Dr. Mary Hughes, for two excellent presentations. I just noticed we've 1 minute left for any questions. If anybody had any questions, I had one for Mary very quickly. Is Mary, do you think gamification is useful for children or adolescents? Do you think that's the way to go?
Absolutely. I think if you can include it in your design phase, it's absolutely crucial, because they will engage more with it, and setting them those targets and, letting them achieve them. It does make it a lot more interactive, and the feedback for the apps that include it and devices does increase engagement. So I think that has to be the key, is engagement, in order to sustain the use of your intervention.
Mm-hmm. Thank you, Mary. And a quick question for Professor Ree. Thank you very much for your presentations. They were so interesting and so much to absorb there. I'm just wondering, is it very expensive when you're trying to do research in this area and trying to develop apps and software? Could you talk a little bit about that?
Yes, it was quite pricey. It's mostly the person cost, because I work with engineers who is worldly renowned people. So it's mostly the personal cost, and the technology is there. And and then as I said, the startup company, they make it fancy. So now they're charging a lot of money. They already marketed the device to the pharmaceutical companies and other research institutions. So they charge over $1,000 or something like that. So it's kind of pricey, but I just told them that come down with the price so that they can be more usable for other people. But insurance, if your insurance covers it, it can be affordable.
Yeah, because they seem very good devices, especially wearable devices like children with diabetes have. They you know they have those wearable devices, so it's kind of an easy way to monitor their symptoms.
Yeah, I think the key is to have a really good team with experts in the multiple areas working together on the same project, isn't that right? And to make it as user friendly as possible in the end product, so you can see how it develops as you go along, and it's refined and it's made more attractive and usable by the end user. So you know, to create a standard enough app across 2 platforms in Ireland will cost you about €40,000 for the tech.
Wow.
So when you add on the development costs on top of that, it's not for the faint-hearted, but as I said, it is very beneficial if you use a research-based approach, not only to the design of the app, but also to the information you're putting into it in order to get good information out of it. So you get in what you put out of these devices, and certainly the one that we're working on at the moment will be able to interact with a lot of the hospital systems. So it's worth spending that money on it to get a good product, and that'll increase its sustainability.
Yeah, that's very interesting and very relevant. I'm wondering, sorry, I have one more question, Professor Ree, for Professor Ree, is was there a lot of interest, like is it easy to get funding in this area because of the high numbers of children experiencing asthma, and it continues to be a problem here as well?
Yes, yes. The NIH has a huge emphasis on mHealth development, because now that's the future, and especially now this COVID era, you know, this technology is becoming even more relevant, because a lot of patients see nowadays is through the telemedicine. So devices like this is going to be a very useful tool, so that the clinicians can see how the patient's doing through the dashboard, instead of just seeing them face to face in person, so that they will become, you know, they know about what's going on with the patients, and make a more the decisions that based on the objective data they see.
I was making a lot of notes while you were talking. I think I really like that idea about the linkage with the dashboard, so that the clinician gets that data and can kind of you know, aim to have more prevention, like help them manage their symptoms better, so that it reduces hospitalizations. And as you say, with COVID now, there's a huge emphasis on delivering mHealth.
Right.
Yeah.
I think there'll be a demand for it. I think people have become used to this hybrid model, and they will demand more interaction with us outside of the hospital setting. So mHealth is the way forward. It's how we augment our service. We're doing a great job, but this is going to be an addition to what we're already doing, and it will impact on their lives and improve their quality of life, improve their self-care behaviour, and give them more ownership of their own condition, because that's key to sustain their engagement, and then for that transition phase into early adulthood, to reduce the unscheduled care episodes.
I'm just conscious that some people have to go, so I hate to wind this up. We could talk for at least another hour on this subject. Just to say, there's lots of thank yous in the chat function to say they're excellent presentations, very enjoyable, and to thank you both today. So on behalf, as the chair of the Children's Research Group, and on behalf of my team, I'd like to thank you both for kicking off our seminar series. It was brilliant. Thank you very much.
It's been a pleasure. Thanks a million, everybody.
Okay, take care. Bye-bye.